Chapter 23, Treatment of Asthma and Chronic Obstructive Pulmonary Disease. We have the learning objectives for this chapter. So those first 8 things here are going to be things that you should know after completing this chapter. We have our key terms. We'll skip over them for now because we'll cover them in the chapter. So asthma is a chronic disease that affects the airways, producing irritation, inflammation, and difficulty breathing. More than 21 million adults and 4.2 million children in the U.S. have been diagnosed with asthma, according to the U.S. CDC. Females are more likely than males to report that they have asthma. The burden of disease attributed to asthma is great because it is responsible for missed days at school and work and increased healthcare costs because of emergency department visits, hospitalization, and outpatient doctor visits. Asthma is the reason for more than 5 million physician office visits annually. Asthma is classified according to the level of treatment necessary to control symptoms or keep symptoms from worsening, according to Global Initiative for Asthma Guidelines. So in box 23.1, we have the classification of asthma. So mild asthma is well controlled with an as-needed low-dose inhaled corticosteroid. ICS formoterol or leukotriene receptor antagonist. Moderate to severe asthma requires high-dose ICAs and LABAs to prevent it from being uncontrolled or asthma that remains uncontrolled despite the treatment. So LABAs are long-acting beta agonist, just so you know. So it's not known exactly why some people get asthma and others do not. However, there are factors that can increase the risk for asthma. A prime example is a positive family history of asthma or exposure to tobacco smoke. Research suggests that during pregnancy, secondhand smoke exposure may be just as damaging to the unborn baby as to the mother. Chronic exposure to other sources of air pollution and exposure to some allergens and infections early in life will also be risk factors. Symptoms of asthma are linked to the progression of physiologic changes in airways. Initially, the airways, which are the bronchial tubule and bronchioles, become irritated. This causes airway constriction, which makes passage of air more difficult. Airways also become inflamed and swollen, further restricting the flow of air through the bronchial passages. Mucus production is increased above normal levels, which can obstruct breathing passages. So figure 23.1 is showing us airway changes during an asthma episode. So one is the edema of mucous membrane, and then mucus plug, and then bronchospasms and muscle contraction, and then obstructed bronchial. Airway constriction, inflammation, and mucus produce characteristic asthma symptoms such as coughing, wheezing, shortness of breath, and tightness. Symptoms may be mild or severe and vary for each individual. During an asthma episode, breathing may be noisy and labored. A whistling or creaking sound may be heard with inspiration and expiration. Patients describe chest tightness that feels as though something or someone were squeezing or sitting on their chest, and the feeling that they cannot get enough air into their lungs. Actually, shortness of breath is associated with reduced expiration rather than decreased inspiration. Breathing may become faster and shallower. Nocturnal asthma is a condition characterized by decreased force expiratory volume in 1 second. The maximum volume of air that can be breathed out in 1 second is reduced. Increased airway inflammation is present along with exaggerated bronchial constrictive, which is hyperresponsiveness. Coughing at night may disrupt sleep. In one study of patients with asthma, as many as 74% reported nocturnal asthma symptoms at least once weekly. And nocturnal asthma, lung function, and inflammatory hormones decrease in the release of pro-inflammatory mediators like cytokines and leukotrienes increases in the middle of the night according to the patient's circadian rhythm, which is our biological clock. Box 23.2 lists the common symptoms of asthma. Asthma triggers are things that can precipitate an asthma episode in individuals with asthma. An asthma episode is also called an asthma attack. Examples of triggers are allergens such as animal dander, pollen, air pollution, cleaning fluid, mold, tobacco smoke, and even cold air. Exposure to cockroach droppings and air pollution is linked to the rise of asthma in inner city youth. Other triggers are upper respiratory infection and strenuous exercise. The risk for exercise-induced asthma can be minimized by taking prescribed medications before exercising. So box 23.3 lists those allergens and then irritations. So we already talked about the allergens, but for some of the irritants, we have cigarette smoke, air pollution, cold air changes in weather, strong odors from painting or cooking, scented products, strong emotional expression and stress, that's including crying or laughing hard. Other things can be medications such as aspirin and beta blockers, sulfites in fruit, like dried fruit, or beverages like wine. Gastroesophageal reflux disease and laryngopharyngeal reflux, which can worsen asthma symptoms. Irritants or allergens that one may be exposed to at work, such as chemicals or dust. Asthma symptoms can be managed with a combination of medication, lifestyle modification, and home monitoring using a peak flow meter to measure volume of expired airflow. Medications that are administered for the treatment and management of asthma are divided into two classes. They treat the two main components of asthma, airway inflammation and acute bronchoconstriction, constriction of the airways. Rescue medications treat the acute symptoms. They include short-acting beta adrenergic agonists such as albuterol and short-acting anticholinergic agents like ipratropium bromide. Maintenance therapy is used to prevent asthma episodes. Maintenance medication include long-acting beta adrenergic agonist like salmeterol, inhaled corticosteroids like budesonide, leukotriene modifiers like montelukast, mast cell stabilizers like cromolyn sodium, long-acting anticholinergic drugs like tiotropium bromide, and xanthine derivatives like aminophylline. The key to preventing asthma attacks, hospitalization, and death from asthma is reducing and preventing further inflammation. Sublingual immunotherapy has been administered with an aim to desensitize an individual to specific asthma triggers. The therapy involves exposing the individual to increasing doses of an allergen. Studies have shown mixed results regarding the effectiveness of sublingual immunotherapy. A peak flow meter is a handheld device used to measure the volume of air exhaled and how fast air is exhaled. Regular measurements can enable a person with asthma to spot trends that signal an impeding attack. A peak flow meter permits patients to manage their asthma symptom control. Low peak flow numbers signal that asthma is not controlled. Spirometry is a test that is performed to measure the volume of air that is expired, blown out of the lungs after taking a deep breath, and how rapidly the volume of air is expired. All right, so drugs used in the treatment of acute symptoms. So this is what we as pharmacy technicians are going to work with is the medications to treat uh, asthma. So, rescue medications, also known as relievers, provide rapid and short-term relief of asthma symptoms. Um, Current global initiative for asthma guidelines recommend as needed low-dose inhaled corticosteroids as the preferred symptom reliever. However, administration of a short-acting beta adrenergic agonist may alternatively be used. Albuterol is a short-acting beta adrenergic agonist, so that's a SABA, that relieves bronchospasms and opens airways. It is a bronchodilator. Other beta adrenergic agonists prescribed for the treatment of asthma include levoalbuterol and terbutaline. Adrenergic agonists are commonly administered by oral inhalation using a metered dose inhaler or nebulizer. Ipratropium bromide is a short-acting anticholinergic that is administered by the inhalation route. Ipratropium bromide may be administered singularly or in combination with a short-acting beta adrenergic agonist for the relief of acute symptoms. Bronchial airways are composed of smooth muscle that is innervated by beta 2, alpha 1, and alpha 2, and muscarinic M1 and M3 receptors. Short-acting beta adrenergic agonists relax bronchial smooth muscle, causing airways to dilate and thereby reversing bronchospasms. Levoalbuterol is an isomer of albuterol and is moderately selective beta adrenergic receptor agonist. Pharmacokinetics, so short-acting beta adrenergic agonists have a rapid onset and a short duration of action. So what that means is that it starts working really quick, but does not last very long. The onset of action for albuterol is within 15 minutes, and the peak effect occurs within 30 minutes to 2 hours. So the peak effect is when it is working the best. So working the best at 30 minutes to 2 hours. The duration of action of albuterol is 2 to 6 hours compared with its isomer levoalbuterol, which has a duration of action of approximately 3 to 6 hours. So that's how long the drug is going to work in the body. The bioavailability of ipratropium bromide is low, which accounts for the low incidence of adverse reactions. Drugs such as albuterol can produce nervousness, difficulty sleeping, dry mouth, mild headache, and throat irritation. Beta receptors are also located on heart and skeletal muscle, so the use of beta adrenergic agonist can increase the heart rate and lead to arrhythmias, hypertension, palpitations, tachycardia, and tremors. Beta receptors are also located on heart and skeletal muscle, so the use of beta adrenergic agonists can increase the heart rate and lead to arrhythmias, hypertension, palpitations, tachycardia, and tremors. Beta adrenergic stimulation may also produce hyperglycemia, hypokalemia, and increase insulin secretion. Ipratropium bromide can cause difficulty urinating and blurred vision. All right, then we have our list of medications. So we have albuterol, and then these are all the different brand names. So keep in mind that this book does list Canadian drugs, which we don't need to worry about as pharmacy technicians in the US. So you can completely ignore those. So that's what this is here. And then down here, this is all. So this is the only things that we need to worry about. And then it also gives you the dosage forms and strengths. Same with levoalbuterol and all of the other medications we talked about. Combination Respirmat, which is a SABA and short-acting anticholinergic and anti-muscarinic drugs. All right. For maintenance therapy to prevent asthma flare-ups, drugs that are intended for long-term use and taken daily to prevent asthma symptoms are called controllers. The five classes of drugs used for asthma prophylaxis are long-acting beta adrenergic agonists, inhaled corticosteroids, leukotriene modifiers, mast cell stabilizer, and xanthine derivatives. So what prophylaxis means if you're not aware, that just means that you're taking something to prevent something. So in this case, it would be taking drugs for long-term use so we don't have those asthma flare-ups. So the U.S. Food and Drug Administration updated the indications for the use of long-acting beta agonists for the treatment of asthma because of safety concerns. To ensure the safe use of these products, the following guidelines are recommended. LABAs are contraindicated without the use of an inhaled corticosteroid. Single ingredient LABA should not be used alone. LABA use should be limited to the shortest duration of time required to achieve control of asthma symptoms and then discontinued. Long-term use of LABA should be restricted to patients whose asthma cannot be adequately controlled with controller medications. Combination inhaled corticosteroids and a LABA are recommended for pediatric and adolescent patients when the addition of a LABA is required. So here's our chart with long-acting beta-2 adrenergic agonist. So remember the top line are things available in the US, and then here's all the generic names, and these are the brand names. Glucocorticosteroids are anti-inflammatory drugs. They reduce the inflammatory response in airway cells, decreasing the mucus and swelling that make breathing difficult. Glucocorticoids decrease the synthesis of pro-inflammatory substances like prostaglandins, leukotrienes, and cytokines that are released as part of the inflammatory response. The primary route of administration for corticosteroids used for the treatment of asthma is inhalation. However, they may be administered orally for more severe symptoms. Inhaled corticosteroids include beclomethasone, budesonide, cyclosinide, fluticasone, and mometasone. So adverse reactions to inhaled corticosteroids are primarily local, include coughing, hoarseness, throat irritation, dry mouth, flushing, loss of taste, or unpleasant taste. Some patients can develop an infection in the mouth or throat called thrush. However, the risk can be minimized by gargling or rinsing the mouth after administering each dose of medication. Systemic efforts are dose dependent and more likely to occur at higher doses. Flovent HFA is contraindicated in children younger than 4 years of age, and budesonide, beclomethasone, and triamcinolone inhalers are contraindicated in children younger than 6 years of age. Symbicort and Advair are contraindicated in children younger than 12 years. So remember, contraindicated means not indicated. And indicated means that they are for that population or that disease state. Contraindicated would be the opposite. So we have our list of inhaled corticosteroids. So we have went through and just like the other tables, we've went through them briefly in the chapters, but you can read up more on them and practice the generic and brand names and look at all the different dosage forms and strengths uh, when you review the chapter on your own. Leukotrienes are pro-inflammatory substances that are released as part of the inflammatory response. Leukotriene modifiers are administered to patients with mild asthma to reduce inflammation. Mechanism of action. So montelukast and sofrlucas interfere with the binding of leukotrienes on airway smooth muscle, reducing allergen-induced airway inflammation, airway relaxation, and edema. Montelukast is readily absorbed when administered orally. Montelukast and Zofranilukast may produce a cough, hoarseness, or sore throat, headache, indigestion, heartburn or stomach upset, runny nose. It can also produce difficulty sleeping, dizziness or drowsiness, muscle aches or cramps, and unusual dreams. Xyluin extended release tablets may produce abdominal pain in addition to the adverse reactions listed for Montelukast and Zofranilukast. So Montelukast also comes in granules that can be mixed for children or people that cannot take a pill orally. So those should be not open until they're ready to be mixed. Once open, the packet contents must be administered within 15 minutes. So here is Montelukast and Zofranilukast and Xyloton. Mm. So mast cell stabilizers, mast cells are released as part of the immune system's response to allergens. Mast cell degranulation leads to the release of histamine and mediators of inflammation. Cromolyn sodium is an example of a mast cell stabilizer. Cromolyn is administered for prophylaxis and does not control acute symptoms. So you're taking this to prevent allergy attacks, not when you are having an allergy attack and looking for relief right away. Cromolyn sodium reduces the release of inflammatory substances responsible for producing the symptoms of asthma by making mast cells less reactive to antigens. It inhibits the degranulation of mast cells and prevents the release of histamine and slow-reacting substance of anaphylaxis. Cromolyn sodium improves exercise tolerance and reaction to cold air and environmental pollutants by reducing hyperactivity of the bronchi. Cromolyn sodium is not used to treat acute symptoms. Several weeks of therapy are required before maximum response to the drug is achieved. Cromolyn sodium can be administered by using an MDI, so it's a meter dose inhaler or nebulizer. Systemic absorption of cromolyn sodium is minimal, so side effects are generally localized. The most common adverse reactions are bad taste in the mouth, irritated dry throat, and coughing or wheezing. Theophylline is a xanthine drug. Xanthines are one of the oldest class of drugs used for the treatment of asthma. Theophylline occurs naturally in tea and is chemically similar to caffeine. A common ending for xanthine derivatives is xylene. Xanthines have bronchodilator and anti-inflammatory properties. The exact mechanism of action of xanthines is unknown. However, the drugs are known to inhibit the release of inflammatory substances and act on bronchial smooth muscle to reduce bronchospasms. The half-life of theophylline varies with the patient's age, liver function, smoking status, and use of concurrent drugs. Smoking decreases the drug's half-life by nearly 50%. In children ages 1 to 9 years old, the half-life can be as much as 50% shorter than in adults. Liver disease and pulmonary edema can prolong half-life up to 24 hours. Theophylline is extensively metabolized by the CYP450 enzyme system and is involved in numerous drug interactions. The bioavailability of theophylline varies by manufacturer. It is recommended that patients receive the same manufacturer's product each time that their prescriptions are filled. So box 23.4 lists the modifiers of serum blood levels of theophylline. So drugs and foods that increase the levels. So oral contraceptives, erythromycin, calcium channel blockers, cimetidine, caffeine, and chocolate. And then these drugs decrease the levels like phenobarbital, phentoin, and carbamazepine. Xanthine derivatives may produce insomnia, dizziness, headache, irritability, decreased appetite, stomach cramps, and urinary retention. So monoclonal antibodies are drugs that you can see here have the ending of mab. These are monoclonal antibodies that are indicated for the treatment of moderate to severe allergic asthma. They decrease the body's response to asthma triggers. Asthma triggers and environmental allergens can cause a hypersensitivity reaction that produces overexpression of immunoglobulin E, which is IgE, antibodies that cause asthma symptoms. Monoclonal antibodies are indicated as an add-on therapy for patients whose asthma is not controlled with inhaled corticosteroid and beta-2 adrenergic agonist. So again, a common ending for monoclonal antibodies drugs is the action of monoclonal antibodies used for the treatment of asthma is specifically directed towards interleukin 5. They prevent early and late stage allergic responses as well as the release of inflammatory mediators like cytokines because of their inhibitory action on the interleukin 5. So, benralizumab, dupilumab, all the MABs are mostly administered by subcutaneous injection, and rislizumab is given by intravenous infusion once monthly. Maximum effects are achieved after 3 days to 2 weeks of administration, depending on the agent administered. The most common adverse reactions are mild redness, itchy swelling, or bruising at the injection site, headache and nausea. More serious adverse reactions that may be a prelude to anaphylaxis are difficulty breathing, hives, and skin rash. So we have the table with all the MABs here and all the different dosage forms and strength. Chronic obstructive pulmonary disease is a progressive disease of the airways that produces a gradual loss of pulmonary function. Emphysema, chronic bronchitis, and chronic obstructive bronchitis are all classified under the heading of COPD. The lungs and airways of patients with COPD are chronically inflamed and air sacs are destroyed. Inflammatory cells infiltrate the airways. So, risk factors for COPD, age, disease, and various lifestyle and environmental factors contribute to the risk for developing COPD. It is more typical in individuals older than 40. Cigarette exposure or smoking is the leading cause of COPD. 75% of people with COPD are former or current smokers. Occupational irritants to the lungs, such as asbestos, industrial chemicals, dust, and air pollution may all contribute to or worsen existing COPD. A history of chronic asthma is also a risk factor, and viral infections can aggravate COPD. So, viruses like adenovirus can affect and aggravate COPD. Airflow obstruction produces shortness of breath. People with COPD may also exhibit a chronic persistent cough and wheezing. Airways become clogged with mucus, making breathing more difficult. The aim of COPD management is to relieve symptoms in airway obstruction, increase oxygen, and treat any precipitating factors and or comorbidities. Pharmacologic treatment of COPD involves the administration of bronchodilators, glucocorticosteroids, and when infections are present, antibiotics. Non-pharmacological treatments include oxygen therapy and mechanical ventilation. Current recommendations support the administration of bronchodilators and long-acting muscarinic antagonists and long-acting beta-2 adrenergic agonists. Combinations as first line of maintenance therapy. The use of glucocorticosteroids to reduce inflammation in open airways was described earlier. Usual doses administered for the treatment of COPD are listed in the drug table at the end of this chapter. So This is the pharmacotherapy chart for COPD. So it tells you the grade and then the recommended pharmacotherapy. This chart lists anticholinergic drugs, their generic and brand names, and dosage, form, and strengths. This chart shows the phosphodiesterase 4 inhibitor, which is Daliresp. The exact mechanism for improving COPD symptoms is unknown. However, it is related to increasing cyclic AMP in lung cells. Delivery of the prescribed dose of medication using an MDI is fast, but may be challenging for some individuals and is inappropriate for small children. It is not uncommon for a substantial amount of the drug to be delivered to the back of the throat rather than into the lungs when an MDI is used. A dry powder inhaler is similar to an MDI, but the medication is in powder form rather than a liquid form. A puff of the powder is inhaled rather than a mist of the liquid. A nebulizer is a device that converts a liquid dose of medication into an aerosoled mist that can be inhaled by normal breathing when used with a mask. A mouthpiece may also be attached to the end of the nebulizer and the mist inhaled using slow, deep breaths. So here is someone using a nebulizer. You may have seen that in friends or family. A spacer is a device that is attached to the end of the MDI. The drug is sprayed into the device's chamber and then slowly inhaled into the lungs. Some devices produce a whistling sound to alert the patient when inhalation is too rapid or not controlled. So here is the summary of drugs used for the treatment of COPD. And this um, chart lists the usual adult oral dosing and the dosing schedule along with warning labels. So those auxiliary labels at the that are placed on the bottle. And here's that spacer. And make sure you check out the key points to help you learn and understand this chapter better.